Hi everyone. It's a pleasure to be speaking at the BioConference Live today. I'm going to be talking about practical considerations for the clinical interpretation of germline sequence variants in the era of next-generation sequencing. My name is Heather McLaughlin, and I'm currently an assistant laboratory director at the Laboratory for Molecular Medicine. My office is in Cambridge, Massachusetts, and I'm also an instructor at Harvard Medical School and the Massachusetts General Hospital. So in terms of starting out, I just wanted to do a brief disclosure. As I said, I am an employee for the Laboratory for Molecular Medicine, and we are a fee-for-service genetic laboratory. And I briefly wanted to give an outline of my talk. So we're going to start out by talking about the evolution of clinical molecular genetics. So where have we been and sort of where are we going in the future? Talk a little bit about what is variant interpretation. I have a lot of case examples to show you with interpretation considerations and pitfalls, and then we'll end by learning about how to construct variant interpretations to put on clinical reports. Oh, and I forgot to say at the beginning, if anyone has any questions, feel free to put them in the Q&A, and then I'll try to address them at the end if we have some time. So, as many of you probably realize, the evolution of clinical molecular genetics is really growing. So we started out several years ago doing just genotyping, and during that time, interpretation of sequence variants wasn't really required because by definition we were looking for variants that we already knew were pathogenic. However, as things have evolved to go to single gene sequencing and then onto gene panels which can contain anywhere from 5 to hundreds of genes, and now exome and genome, which include thousands and thousands of genes, the need for variant interpretation has greatly increased. So in terms of our experience at the Laboratory for Molecular Medicine, we have now performed diagnostic testing for over 15,000 probands, and we cover many different disease areas ranging from cardiomyopathy to hearing loss to pulmonary disorders. And one thing that we have noticed over time, I think at the beginning we sort of expected that after a while we would sort of see all of the novel variation in some of the genes that we're testing. But in fact, this is not the case. So as you can see on my slide here, about 68% of probands have a likely pathogenic or pathogenic variant that we only see a single time. And 96% of variants are seen less than 10 times. So what this really means for us in terms of variant interpretation is that this is going to be a long process. I don't think it's going to end anytime soon. And in every single case that you see, there are many, many new variants that are identified in patients that need to be assessed for pathogenicity. So what are we talking about when we're talking about variant interpretation? I think the questions are pretty simple. The first is, does the variant disrupt protein or gene function and therefore protein function? The second question is, can this disrupted function lead to disease? And then the third and probably most important question for clinical reports is this disrupted gene function causative for my patient's presentation? So the variant assessment process that we have established here at the Laboratory for Molecular Medicine brings in a lot of pieces of variant interpretation. So usually what happens, we run a lot of next generation sequencing tests. So we'll get the lab result that will have various variants that have been identified in that individual, and then we really get to work trying to do the variant annotation. So we look at a lot of things. We look at published and in-house data. We look at segregation studies that are available from that published data and then also within the family itself. We look at things like population frequency, amino acid conservation, pathogenicity prediction, splicing tools. So all of those things go into a variant interpretation, and then we take that knowledge along with the clinical data and the custom knowledge that we have about the gene or disease area, and perform a variant classification. And I'm going to talk a little bit more about the criteria that we use to provide these variant classifications that I've described below. But in general, we have the 5 variant classification categories that have been proposed by the American College of Medical Genetics and Genomics. So this ranges from benign all the way to pathogenic. And then on our clinical reports, we choose not to report back the benign variants, but anything that's likely benign to VUS to likely path or path is put on the clinical report. And a lot of times what we see is that if we do family testing and have more segregation data, or if we gather additional info, we kind of come back to this variant classification sometimes, and indeed sometimes the variant classification will change based on this information. So the process is sort of fluid, and things can progress either way depending on what kind of information that you have. So next I wanted to just go through some of the items that I've listed that go into the variant annotation process, and sort of talk about common pitfalls and things to think about when we're looking at these. So the first thing I wanted to talk about is population frequency, and I've provided a couple of websites here that we commonly use to gather population frequency info. So the NHBLI Exome Sequencing Project server is a great one, and that has a lot of information for European Americans and African Americans. And then dbSNP in 1,000 Genomes also has several other populations. And what we're really asking when we're looking at population frequency is, compared to the prevalence of the disease or phenotype that we're trying to assess, is this variant rare? So for example, one of the diseases that we test in our laboratory is cardiomyopathy. And so if we saw a variant below in this example, MYBPC3, we see that this missense change is present at a minor allele frequency, or MAF, of 1.4% in African Americans. So when we're going to assess a variant like this, in the back of our minds, we know that the prevalence of hypertrophic cardiomyopathy, if that was the patient's indication, is about 1 in 500, or 0.2%. We can automatically know that 1.4% minor allele frequency for a variant, even if this was the only disease-causing variant in the entire gene, or only for HCM, which we know isn't the case, the variant frequency is much too high to be causative for Mendelian disease. So automatically a variant like this we would suspect to be more likely benign. There are a lot of common pitfalls in looking at population frequency. So the first one is that indels are troublesome, and this is because of the way that insertion deletion variants are aligned. So sometimes it can be very difficult to tell if these variants are actually absent from public databases, because sometimes the data quality isn't all that good, and so it may look like the variant isn't present in some of these databases when in fact it was just a data quality issue. Population cohorts are also somewhat homogeneous, so I mentioned that in the ESP cohort on the previous slide. It basically covers European Americans and African Americans. So if you're sequencing populations or individuals who aren't represented in those populations, we need to be very cautious, because it's going to be difficult for us to determine if a variant that we find is part of the benign spectrum of variation in that population, or if it truly is a rare variant. And there really is no way to tell until we have a good control population. The other thing is, on the previous slide, I just showed you how we can use population frequency data and prevalence estimates to determine if a variant may be pathogenic. And in that example, HCM is a really well-studied disease, and we think we have a pretty good grasp on the prevalence of that disease. But many diseases, especially ones that are more rare, have prevalence estimates that are sort of more guesstimates, and so it can be really difficult to compare the frequency to disease prevalence. So the example that I gave in the last slide, we have to be really careful when we're using population frequencies to infer pathogenicity. Another issue to think about is reduced penetrance. So we deal with this a lot in our lab in terms of cardiomyopathy, because some individuals who have pathogenic variants do not display the disease, and in this case it may lead to the variant existing at a higher population frequency than might be expected due to less selective pressure. So that's something to always keep in consideration. And then of course, on the flip side, recessive variants may also be present at a high frequency. So some really common pathogenic variants, for example, Delta F508 and CFTR is present at a little bit higher frequency than other pathogenic variants. So a lot of recessive variants are that way. And then one final thing to think about is that high frequency variants may still impart some disease risk. So there's a variant that we come across sometimes in our lab in SCN5A, the minor allele frequency is actually quite high at 7% in African Americans. However, published studies have shown that this may be a risk allele for arrhythmia, and the odds ratio is about 2.5. So instead of calling this variant benign just based on the allele frequency alone, we may still want to include it on the report. We might be able to say it's probably benign for Mendelian disease, but it might still impart a disease risk. So in terms of conservation analysis, I think everybody is sort of probably familiar with this concept, and what we're really asking is, has the effect of nucleotide or amino acid resisted change throughout evolution? So I've given an example here of two amino acids, one with quite high conservation and then one with low conservation. One thing that we also can look at is nucleotide conservation and looking at the presence of a nucleotide change in other species as well. So you can kind of do it both at the amino acid level and at the nucleotide level. I think the big take-home point here is that lack of conservation may indicate that the variant could be benign. And it's not really just lack of conservation that we're looking for, it's actually the variant amino acid present in another species. So let's say I have a threonine to alanine change, and alanine is present in many, many mammals. I might not expect that variant to be pathogenic. However, if you have a situation like this low conservation variant that I'm showing here, the only thing that we can say is that cysteine and serine seem to be tolerated, but we cannot say that other amino acids may not be tolerated just because this is low conservation. So I think a huge point to take home here is that a variant with extensive conservation by itself does not really provide evidence for pathogenicity on its own. It's just saying that that variant or that amino acid position rather, is well conserved. So we should never be using conservation analysis alone to classify a variant. I next wanted to talk about the subject of pathogenicity prediction. So I've listed a couple of programs here. There are certainly several others, and most of these tend to use a combination of conservation, amino acid characteristics, and protein structure to infer pathogenicity from missense variants. And I'm going to give an example on the next slide of sort of the output that we might see for these. So this is just an Excel table of various outputs for some of these, and I've tried to indicate in red if the call would say that this variant was pathogenic, in orange if it's possibly pathogenic, or in green if it's the prediction program is calling a variant benign. So on the top here, you can see that all of these computational pathogenicity prediction programs are in agreement that the variant may be pathogenic, and on the bottom, they're all in agreement that it may be benign. But the example that I'm providing in the middle is usually something that we see quite often, which is that some of them call the variant pathogenic, and then some of them call them benign. So the big take-home point here is that these are only predictions. These pathogenicity prediction programs should never be used to directly classify a variant. I think it's okay to use them as part of an overall interpretation process, but they shouldn't have a significant influence on your classification, and it certainly shouldn't overrule other sources of data like allele frequency, segregation with disease, functional data, things like that. Those are much more stronger pieces of evidence than pathogenicity prediction programs would be. I think sometimes people are sort of surprised that you can't just use these prediction programs to classify variants, but I think it's really important to use more genetic evidence and functional evidence to classify variants. One other kind of prediction that we can use are splicing predictions, and a program that we often use for this is Element, and that's where the examples are provided here. But really what we're asking are the splice sites sort of affected, or does a variant lead to the creation of a novel splice site? So on the top here, I've shown an exon, and you can see where the ±1,2 spots are that are the common splicing positions, and then also the +5 position, which I've indicated with an arrow, which is the 5th most conserved base of the splicing region. So one gene where splicing variants are commonly found and are pathogenic is the MYBPC3 gene. And what I've shown here is a variant that leads to the ablation of a 5' splice site. So you can see that all the pathogenicity prediction programs at the top are calling this variant a 5' splice site, but after this variant change, we see that the splice site is abolished. And so that's really what we're looking for when we're trying to decide if some of these splicing predictions are giving us any information. I think one other important thing to point out is that I think it's important to look at splicing predictions even for variants that are missense, because sometimes we do see perhaps the creation of a novel splice site. So again, this is the same gene, MYBPC3, and we see that this variant, even though it is a missense variant, it seems to be creating a perhaps novel 3' splice site. So those are always things to keep into consideration when you're looking at splicing predictions. There are a lot of common pitfalls with splicing predictions. So the first thing to notice is that a lot of these algorithms are noisy. So this is just a snapshot of a gene region, and you can see that many of the prediction programs are calling 5' splice sites sort of all over the place. Obviously, many of these probably aren't real, and then there's also one program that's calling many 3' splice sites all over this region. And so a lot of these probably aren't real. So I think you have to have an eye towards false positives for these, and to know that this, again, is just a prediction algorithm and is not really telling us what's actually happening with the splicing machinery. Certainly in vitro data, things like mini-gene assays that can support the splicing predictions are excellent to have. However, these may not always represent biological function. And in vivo data, so if we can get mRNA data from actual human individuals with these variants, that is really best, but unfortunately, from our experience, that's rarely available in the literature. So just a word on nonsense frame shift and 1-2 splice variants. So these are commonly assumed to be pathogenic, and this is because of the high likelihood of a severe impact to the protein. So nonsense and frame shifts usually lead to premature stops, and 1-2 splice can lead to exon skipping, which would lead to a frame shift and a premature stop. We need to be careful with these variants because although most of them will be deleterious to the protein, not all of them may result in disease. And in fact, there are many genes where we know that we can lose one copy of the gene and be absolutely fine with no phenotype. Another thing to be take into consideration is where the variant is located. So if loss of function variant is occurring in the last exon, it will likely escape nonsense-mediated decay and may lead to a truncated protein as opposed to an absent protein. So an example of this is a loss of function variant in the BRCA2 gene. Now, normally loss of function variants in BRCA1 and 2 are considered to be pathogenic. However, this particular variant resides in the last exon. And on top of that, we know that it's present in 0.8% of European Americans in the exome sequencing project. So what we think is probably happening is that this variant likely escapes NMD. Certainly the population prevalence or frequency of this variant is much too high to be leading to Mendelian BRCA1 and 2 associated cancer. And so this variant has actually been classified as likely benign by many different laboratories with respect to that. So it's always good to kind of look at where the variant is at, and then sometimes population frequency data can give you a little bit more information, which is great. So review of published data, again, I've just tried to provide a couple of helpful resources. The Human Genome Mutation Database is great. ClinVar is starting to be populated with variant classifications from many different laboratories, and if you're in a laboratory that hasn't contributed yet, I really encourage you to contribute to this website. I think it'll be very important. And then there's also PubMed and obviously many locus-specific databases, and the HDVS website has a really great list of databases for various diseases. So what are we really looking for when we're talking about published data? Obviously, we really want to try to find other patients or families with this variant. It's really important to note the race or ethnicity of these patients and families, if there's any consanguinity, what the disease is. So sometimes we see variants in many different diseases, and so you really have to sort of parse that out. It's important to note if there are any de novo occurrences of this variant. And then I think probably most importantly is their segregation of this variant with disease, or actually on the flip side, does this variant not segregate with disease? There are also a lot of case control studies that you may be able to find in the literature for certain variants, and certainly functional studies. And anytime that we can find an in vivo study as opposed to an in vitro study, that's all the more better, but a lot of times we just have to take what we can get. So in terms of reviewing published data, the first common pitfall I want to talk about is race and ethnicity. So unfortunately, as I alluded to before when looking at population frequency, there is little data available for some populations. And a variant that you see that comes out of clinical sequencing may be a frequent variant in certain ethnic or geographic populations. So I have an example here of a variant in the PTPN11 gene. This gene is associated with Noonan syndrome and other associated disorders. So this variant had been previously published as pathogenic in several papers for Noonan syndrome. It had been reported in 7 probands with the clinical features of Noonan syndrome, but this variant had also been found in 2 unaffected parents. And a patient received this variant back on a report and decided to contact the author of the paper. And the author of that paper said that he later found this variant in 3.8%, or 3 out of 80 Ashkenazi Jewish controls, and that author now feels the variant is benign. Our laboratory has identified this variant in 3 Ashkenazi Jewish probands with Noonan syndrome, and now we think this variant is likely benign based on the high frequency in the Ashkenazi Jewish population. And I think it's really important, this gene really illustrates why it's important to think about race and ethnicity and what population data is available, because variants in the PTPN11 gene are oftentimes used to make reproductive decisions. So we have a lot of women who receive prenatal screening or prenatal sequencing for fetuses with increased nuchal translucency. And if we report a variant like this out as pathogenic, there could be conception choices that are being made based on this decision. So it's very, very important for us to take into consideration the race and ethnicity of a patient when we are assessing variants. Another common pitfall is consanguinity, and so when we think about consanguinity, by definition, we know that individuals who result from consanguineous marriages will exhibit a high degree of autozygosity. So basically what that means is we expect to see many large homozygous stretches throughout the genome. So one variant that we came across in a genome sequencing study when we were doing an incidental findings analysis was this variant in the MED25 gene. This variant was originally reported in a large Costa Rican family with autosomal recessive Charcot-Marie tooth disease. And interestingly, this variant was found in all affected individuals, so that's 22 segregations. And in the genetic world, in clinical genetics, 22 segregations is huge. We never see that many segregations. So this really was quite a bit of evidence towards this variant being pathogenic in disease. However, when we were doing an analysis on this variant, we noticed that in 5 years since this original publication, no other reports of this variant or gene in association with CMT or any other diseases have been reported, even though we now know that the minor allele frequency of this variant is about 0.5% in the Exome Sequencing Project database. And so given that the minor allele frequency is so high, we would have expected to at least see one additional patient with this gene disease association. And so that kind of calls into question this variant and its role in disease. And I think it's really important to think about consanguinity in this situation, because what may be happening is that this variant may be tagging another disease-associated variant that is linked to this variant somewhere else on the same chromosome. And so we need to be very careful, even when we have this many segregations in families with consanguinity, especially if it's the only time this variant has ever been reported. One other thing that we commonly deal with in our lab is non-segregation, and so I'm going to talk about this today in the context of cardiomyopathy, because non-segregation can occur sometimes, and I think in the presence of genotype positive, phenotype negative individuals, for some disorders may be acceptable. And so cardiomyopathy is one of those instances because we know that this disorder has both reduced penetrance and late onset. So the top family that I'm showing you here has a family, so this 30-year-old individual with left ventricular hypertrophy, which would be a sign of hypertrophic cardiomyopathy, and they also had arrhythmia, and we know that this individual had a family history of sudden cardiac death. So they were positive for a variant that we know to be pathogenic in our lab. However, this individual's brother was also positive but not yet displaying signs of disease. In this case, this isn't really evidence against disease, especially because we've already established that this variant is pathogenic. And so what will happen for this individual is probably more of a wait and see approach, and knowing that they have this variant and that their echo has been normal, we will kind of just wait and see what happens with that individual. This family also had an interesting example because there was a 7-year-old individual who was tested that had a normal echo. And again, because this individual is so young, we might not expect them to have any signs of disease yet. And so it will also be sort of a wait and see approach for them as well. So I think this sort of illustrates situations where you can have genotype positive, phenotype negative individuals, especially in disorders of reduced penetrance or late onset. The second thing I wanted to talk about, although this is rare, it does happen, that some families may have more than one pathogenic variant segregating. And so this is an example of a family that had both a Titin and RBM20 variant, and both of these genes are associated with dilated cardiomyopathy. However, if you did testing and only tested for one of these variants, you would basically see that the variant wasn't segregating with disease, because in some family members, they wouldn't have this variant, but they would still be affected. But that's probably because, like the example of this female individual on the right that has dilated cardiomyopathy and only has the Titin variant, of why a variant may not be segregating. Also in these families, sometimes what might happen if we have two variants that are segregating, sort of coming from both sides of the family, is sometimes we have infants who have very severe disease and sort of unfortunately succumb to that disease at a very young age, and usually those individuals will end up having both variants. So a lot of times if you have two pathogenic variants, for the same disease, we see a much higher degree of the phenotype. So I wanted to take a moment now to talk about case control studies, just really to try to hammer home the fact that you have to have an adequate number of cases and controls, and hopefully these are race matched in order for this information to be beneficial to you. So an example of a lot of times what we see is somebody will say a variant was found in 1 in 100 cases and it was absent from 100 controls. Well, so we have 100 cases and controls, so that's 200 chromosomes. So we've seen the variant in 1 out of 200 versus 0 out of 200 chromosomes. That p-value is literally 1. It's meaningless to us. So in order for this to be meaningful, we would need to screen about at least 2,000 chromosomes to even reach a p-value of 0.05. And again, controls should be race matched. So I would encourage you, especially in older papers that are sort of that had really small populations that they were screening, and trying to say that because they found the variant in a couple of individuals but didn't find it in any controls, when we're only looking at a couple of 100 individuals to begin with, to really to look at that data and to be wary of some of the conclusions that are made. I've provided a link here which I think is a really quick and easy way to do a Fisher's exact test. So anytime that you come across data like this in a paper, you can just put it in to this test and it will calculate a p-value for you. So now I wanted to come around full circle. We've talked about a couple of topics today that go into variant interpretation, and now I wanted to talk about, after we've gathered all this data and sort of annotated this variant with as much information as we have, how do we actually perform the variant classification process and assign this variant a classification, like likely benign, or is this variant a variant of uncertain significance, a VUS, or is it pathogenic? So how do we do that? And I was going to quickly show today, this is a really exciting figure that has come out of the American College of Medical Genetics and Genomics Lab QA Committee on the interpretation of sequence variants, and I've provided, I tried to fit it in at the bottom, a link at the below that everyone can go in. If you are an ACMG member, you can view this content. But basically, this work group has done a really excellent job of coming up with sort of what strength of evidence is required to call something pathogenic or benign, and if we should consider the evidence that we have in hand supporting evidence, so not really having a lot of pull on the final variant classification, anywhere from moderate evidence or very strong evidence. So I'm not going to spend too much time on this slide. Hopefully everyone can kind of go back later and take a look, but what I hope you can appreciate is that things like segregation really make things, a variant maybe be more strong, and some of the things that we talked about today, like just looking at pathogenicity prediction programs, may only provide just supporting evidence. So I encourage everyone to go to this website and take a look at the work that this Lab QA committee has done. So once we're done and we've classified a variant, how do we construct a variant interpretation? So the contents of variant interpretations should include a lot of the things that we've already talked about before. So reports in the literature and maybe any lab-specific data that you may have from testing this gene or disease previously. We should always include the population frequency of this data, any pathogenicity prediction programs and conservation that we have seen, any functional data. We should always note if the variance is nonsense frame shift or splice, that we would expect this variant perhaps to lead to nonsense mediated decay, except if it's in the last exon. And then we should say any gene or disease specific information that we might have and sort of provide this with a summary sentence. And so what I wanted to do just at the end of the talk is just give a case example. This is a pretty easy case example. Obviously it's not always this easy, but in this case, this was an individual who came in with an indication of hypertrophic cardiomyopathy. This patient underwent genome sequencing, and surprisingly we found a variant in PTPN11, which I talked about earlier. This gene is associated with Noonan syndrome and also Leopard syndrome. So let's go take a look at a couple of these different things that we can look at. So the first is population frequency, and we noticed that this variant was not present in the exome sequencing project database or in 1,000 genomes. This variant was pretty well conserved down to zebrafish. In terms of the pathogenicity prediction programs, this variant was called benign by 1 prediction and pathogenic by 3 prediction programs. There was no predicted effect on splicing. And this is really the evidence that we're looking for. So this variant has been identified in over 40 individuals with Leopard syndrome. It's segregated with disease in 4 affected relatives. And importantly, this variant has been confirmed de novo in multiple cases of Leopard syndrome. And functional data for this variant, in vivo functional data, actually showed impaired catalytic activity. So what we would do for a variant like this, I just wanted to provide you with an example of what a variant interpretation might look like. So I'm just going to, I'm not going to read this variant interpretation out loud, but I think this is the kind of information that we want to be providing on clinical reports. We want to state the facts, things that we have found, like the number of individuals that has occurred in. If it's occurred de novo, we want to be able to cite the manuscripts and the papers that we have found this data in, just so that our clinicians, the genetic counselors, the patient even, can go back to any of these papers and sort of look at the data themselves. So to start wrapping up here, variant interpretation cannot be done without some sort of manual curation. So there is no algorithm or program or software that we can use to date that can allow us to perform clinical grade variant interpretations on variants. And although the guidelines are being developed, professional judgment will still be required. So even using those guidelines from ACMG, I think you still have to use your own professional judgment in your disease area or for the gene that you're looking at in order to correctly classify a variant. Some variants may require a group consensus. and interpretations may change over time, and we've seen that in our own lab. So we tend to reinterpret variants of uncertain significance every 3 to 6 months, and I think anytime a clinician comes to you and asks about a variant, it really helps to sometimes reinterpret that variant to see if there's any new literature or any new information about that variant. And then the last point I wanted to make is that disease and gene-specific knowledge may be required. Thankfully, in the world of email and everything else, I think it's really easy to seek external expertise about this if you find a variant in a gene that you're not familiar with. So I wanted to acknowledge at the end Partners Personalized Medicine Laboratory for Molecular Medicine. That's where a lot of these cases came from, and then the Gene Insight team, which is the software program that we use actually to keep track of our variant assessments and interpretations. And I'm just going to leave it on this slide here. So I am going to go to the Q&A and try to answer a few questions. If your question doesn't get answered, I have my email address here on the screen, and people can feel free to email me any questions that you may have. And then if you're interested in the continuing education credits, there's a link here. Let's see some of the questions that we have. So one of the questions here is from Dana from GeneDx, and it says, since genetics is moving so quickly, how often do you do a literature search for variants that you have previously reported? So I think I just said this a minute ago, but it depends on the classification that we gave the variant in the first place. So a lot of times for pathogenic variants, our criteria is such that we require quite a few segregations and a lot of data in order to call that variant pathogenic. So usually pathogenic variants rarely ever get assessed. However, for variants of uncertain significance, especially because things are moving so quickly, you're absolutely correct. We've decided to take a look at those every 3 to 6 months. So anytime we come across a variant again, basically by the time we see that variant again, we usually have to do a variant interpretation on it. So, and I will say that in our lab's experience, that has, although it's a lot of work, for some variants it really does make a difference because there is new data out there. And let's see if I have any other questions. So the other question I have here is that, and this is from Barbara Stout, and it says, if you have an individual that has parents from 2 different homogeneous populations, are the homogeneous population cohorts still useful for prediction? So if you, I think in most cases, yes. So for example, if you had, I think what you're asking, if you had an African-American individual who came from a homogeneous population, and you had a Caucasian individual that came from a homogeneous population, and those 2 individuals mate, you would still be able to use the population frequency data for those individuals. However, if there's no population frequency data available for that cohort, unfortunately, you would not really be able to use that for prediction of allele frequency. So I think we're just about done with questions. Like I said, if anyone has any questions, please feel free to email me and let me know, and I'd be more than happy to answer any questions you might have. Great, thank you, everybody.